Good evening, everyone. Thank you for joining us for the first Scleral Lens Society webinar of the year. Today we'll be talking about the GSLS 2022 summary. Today we have Maria Walker joining us. She is a clinician scientist who specializes in anterior segment inflammatory diseases and managing specialty contact lenses. After graduating from the New England College of Optometry with an OD/MS degree in 2013, she completed a one-year cornea and contact lens residency at the Pacific University in Portland. In 2014, she joined the clinical faculty at the University of Houston College of Optometry and subsequently entered the PhD program. She completed her PhD in the spring of 2021 with a dissertation entitled The Impact of Scleral Lenses on the Eye. In September 2021, she joined the faculty at UHCO as a tenure-track assistant professor, where she focuses on the research of ocular surface and tear film. She also enjoys teaching in the second and third year didactic contact lens theory courses, as well as attending the fourth year specialty contact lens clinic 1 to 2 days per week. Her clinical and research interests overlap and include scleral lenses, keratoconus, and other ocular surface diseases, as well as myopia management. She actively lectures and facilitates in workshops, domestically and internationally, on scleral lenses, and is involved in several research projects at the Ocular Surface Institute and the Texas Eye Research and Technology Center at UHCO. Dr. Walker has won several awards related to contact lenses and research, and is a fellow of the American Academy of Optometry and a fellow and past president of the Scleral Lens Society, as well as an advisory board member of the GPLI. We also have Dr. Dan Fuller joining us, who received his BS degree from Purdue University and his Doctor of Optometry degree from the Ohio State University College of Optometry. He began his career in a hospital-based setting in the U.S. Navy, serving for 8 years. He spent 17 years in private practice as an owner of a multi-site solo practice that emphasized in medical eye and specialty contact lens services. His career in academia began in 1987, and he holds rank as professor, and he's the chief of the Cornea and Contact Lens Service and is the founding supervisor in the Cornea and Contact Lens Refractive Surgery Residency at the Eye Center at Southern College of Optometry. Dr. Fuller lectures nationally and has authored numerous peer-reviewed papers, posters, and performs original clinical research. He is a diplomat of the Cornea and Contact Lens and Refractive Technology section in the American Academy of Optometry, and he is a fellow and the current president of the Scleral Lens Education Society. He has held multiple chairs of leadership serving at local, state, and national organizations, and he is also an advisory board member to the GPLI. So I'm going to let Dr. Walker and Dr. Fuller take over and begin this presentation. If you're having any issues or any questions, please submit them and we will review them at the end.
Thank you, Roxana. And so this, if you can't tell my voice, this is Maria Walker. I am up first tonight and very excited to be with y'all. So this is kind of a fun one. So Dan and I are going to do the outgoing president, ingoing president kind of pass off here, which should be a lot of fun. So what we're going to, just make sure, yeah. So what we're going to talk about is basically twofold today. And so the first is what I get to talk about. So this is scleral lens education at both the International Forum for Scleral Lens Research, which was part of GSLS this year, and also, and that's really what I'll focus on, but then also there's some really cool stuff, especially in the scleral lens super session. So I'm going to kind of mix things that were in different aspects of the meeting. And then Dan is going to talk about some of the posters and dive a little bit into the research. You will see a lot of what we're going to talk about has some research undertones, but hopefully there'll be a lot of really good clinical perspectives to glean from it. So for those of you who weren't able to make it, either live or virtually, we did host the International Forum for Scleral Lens Research, kind of helped kick off GSLS. And so that's what we're going to start with here, and we're going to talk mostly about the second and third session. And I'm actually, if it works out okay and my videos play, I have a backup plan if they don't, but I've got some videos and I took some of the clips out of some of the kind of interesting comments from some of the speakers. So if you weren't able to make it, I just got everything all up and finished with the recording. So they should be up in the next 24 hours or so, and I'll tell you where to get those. But what I want to do first is just chat briefly about that first session that we did. So the first session, which I won't talk that much about because it was my session, it was Jan's session. Those of you who heard it already heard it. I won't repeat things that I already talked about a lot. And you're probably sick of hearing about midday fogging and IOP from me. So you won't really hear much about it. But I do want to touch, also in that first session, Damian Fisher did a really cool virtual presentation and showed, and he actually talked about it in the Scleral Lens session as well during GSLS, but he was talking about conjunctival prolapse. And you can see from these images on the bottom, and those are both images taken straight from his presentation. Most of us know what prolapse is. They were measuring the magnitude, how much it got sucked up, where it got sucked up. These were in normal patients. They looked and they found it occurred in 37% of cases, but they looked at people in different scenarios. So 80% of the people that participated experienced it with at least one of the designs. They did find it was greater nasally temporally, and they confirmed and he talked a little bit about what most of us kind of suspected was really the issue here, which is suction underneath the bottom of the lens. But what I find super interesting, and we got into this a little bit into the discussion, and I actually talked to Jason Jedlicka after this, he did this lecture here, which was a deep dive into corneal scleral shape, but he also did this in the main session as well. And he sent me this picture here during the session, actually one where we were talking about this. And you might be wondering why I threw this picture up all of a sudden. Well, it really has to do with everything that we talked about in session one of the IFSLR, because the midday fogging, you can see in this top left-hand image. So this is this patient here, same patient. Obviously, one eye has a lot more tear exchange, fluorescein you can see in that lens. The other eye looks much tighter. Up here, you can see that looser lens. You can even see some edge lift here with a lot of tear exchange, has a lot of midday fogging over the pupil. So a loose debris-filled lens. And then on our other side, same patient, really suctioned on lens. You can tell because of that prolapse under, but has no midday fogging. So I thought this was really interesting, and sort of, we had this discussion that was, do you fit these lenses tight or loose? And, do you fix midday fogging? Do you fix IOP? Do you fix any issues with conjunctival prolapse? So I think this showed some real evidence that, a tight, more suctioned lens, certainly in this case, actually reduced the fogging, but that suction created and tight fit created some prolapse. So it was really cool to see people in the main sessions talking about the same things we were talking about in the research session, of course. So that brings me to the next point, which is kind of a theme that you see throughout the different talks at IFSLR and really throughout the entire GSLS, which is that this darn landing zone seems like it contributes to everything, right? If a lens is too tight or too loose, you'll get prolapse, you'll get midday fogging, maybe you have IOP changes. Also, there was a talk, and you can see here is another screenshot from our recording from Gendong Yoon, who we'll talk about at the end of my session here, because he was in our third session talking about optics. He's showing these graphs here that lenses, as most of us know, if you're fitting lenses, they decenter inferior temporally. So on almost all these eyes. So, you know, what is the power of this centration and what issues can it cause optically? And, you know, and this all leads back to, you know, is that scleral shape asymmetric? If you're not fitting it well, you're not going to get good centration of those lenses. And so we'll definitely come back to this theme of lens stability and lens centration being of utmost importance when we get to session 3, which is the really advanced optics like higher order aberration, scleral lenses, and presbyopia correction. So keeping this in mind, but was really brought up and is always a theme of talking about scleral lenses, it feels like everywhere we go. Okay, that's all we're going to talk about for that session 1. Session 2, we had several really good speakers here, and I'm going to kind of go through each of them. And so Muriel Shornack, she didn't speak first, but I thought her content was a nice introduction. And so she first pointed out, so she was sharing her latest scope research, and I think this data was collected, it says 2020 here. It was either 2019 or 2020, maybe it was both of those years. But they were looking at what types of indications. So of course, or maybe not of course, but ocular surface disease, as many of us would probably suspect, is not as commonly fit as corneal irregularities. But she then asked for those patients who had fit, and this is actually some older data, but still just looking at what types of ocular surface disease are managed, the primary being dry eye disease. And she had mentioned in her talk too that the GVHD seems to be increasing in, you know, how many practitioners are fitting this in that ocular surface disease category. So I'm gonna play a video here if it lets me, but I'll preface it, and I'll preface the videos because they are short, and so I just took a little clip. Muriel's doesn't have necessarily a summary of what she said, but I loved it because she so poignantly is basically pointing out, she's talking about where scleral lenses land in our toolbox, you know, when do we fit these ocular surface diseases with sclerals? And she has some nice insights. So I'm going to go ahead and play
number 1 therapy. Scleral lenses tended to fit between topical therapy and more aggressive therapies such as a tarsorrhaphy, amniotic membrane, graft utilization, or conjunctival flap surgery. So it looks like we're trying the simple stuff first, and if that doesn't work, we're going to scleral lenses. Now, one possible question for discussion here would be whether or not that is the correct approach. Approximately 50% of the patients that we fit here at Mayo with scleral lenses are fit for ocular surface disease. And I'm always struck by the fact that a number of these patients will come to us after they have already scarred and developed considerable neovascularization due to ocular surface disease. And might be an interesting question to pose to the group as to whether or not we think that's appropriate, or should we be perhaps intervening a little bit more aggressively with scleral lenses in some of those patients with disease that is likely to result in scarring or neovascularization if left untreated.
Yeah, so I thought that was a really nice, and I always love the way Muriel puts her thoughts down. And so, you know, I think that really speaks to, you know, now that we're more comfortable with these lenses, maybe for some of these severe diseases, we should be introducing them earlier. However, I think it's a wonderful segue into who was our keynote speaker, Dr. Jia Yin, who's in practice up in Boston. She's a corneal surgeon. She was sharing research, so she actually sees those patients that have that full neo coming in, and they had actually, her and Jeb Jacobs had done some work and actually had fitted, and they published on this. That's what you can see, 2 of her slides there I framed at the bottom. They published on 13 patients who were fit with the PROS device, and they had neovascularization, some sort of vascularization on the surface of that cornea. And they put bevacizumab in, or basically Avastin, right, an anti-VEGF, so something that should reduce that stimulus for the blood vessel growth. So they put 1% of this, preservative-free, of course, into the PROS device twice daily. And so you can see if you're looking at this case on the left-hand side, she shows A is at presentation, B is improved, and then C, actually, this patient had discontinued the Avastin treatment and had some progression with increased haze. So it sort of shows treatment and then regression if the treatment is removed. Another case here she showed was a post-transplant patient, and this patient was over 10 years out of treatment, you can see in C, and had no occurrence. So just like I did with Muriel, I am going to share, and again, this is about a minute, and this is Gia, and she's does a great job summarizing, but what she's going to do is summarize the outcomes of these 13 patients.
Summarize on the treatment. Most of those patients had treatment for about 6 months. First 3 months, twice a day, usually taper down to once a day for the second 3 months. And then out of the 13 patients, 12 of them had really nice corneal neovascularization regression with the treatment. And also 10 out of 13 patients had a significant improvement in their vision. And then there's one patient I mentioned earlier, after stopping the treatment, her NV actually progressed and then had decrease in vision. All of those patients were followed by a median duration of 5 years. So overall, we have pretty long-term follow-up in this cohort. And very nice to know that for all of those patients, there's no local or systemic complication. I want to mention we had a young gentleman who has familial dysautonomia, which is known to cause cardiovascular conditions. And every time he would check in, Dr. Debbie Jacobs would check his blood pressure and also, talk to his PCP. And then he had no, change in blood pressure or any systemic complication either.
Yeah, and so again, pointing out basically all of their patients did well, 12 out of 13, one didn't do so well, and no adverse events, so no systemic side effects either. So a really interesting and exciting, and for those of you who, again, if you didn't get to see it, I would go and watch her full presentation online. So last, or second to last in this group actually, is John Gels, did also a presentation in this ocular surface disease. And he started out by sharing, that we can use scleral lenses, of course, to manage scleral defects. And he really did a nice job at talking about the Sorolsky paper that really defined, that we use non-preserved antibiotics and sort of the protocol on how to manage these patients switching lenses out overnight if needed. And he talked specifically about a Desmetocele case, which you can see I just copied and pasted into the bottom here. He fit this cornea all the way to the left. There's some funny commentary about that in our discussion, but he fit that Desmetocele and of course showed the progression. They did end up developing bulle, you can see in this middle image, and so they stopped overnight wear and just taped the lids at night. But he does a really good job at talking through this case, and you can see the cornea bulked up again, some scar and haze, but certainly not at risk of perforating. And this was a patient that he had published a case report on. They had an AV malformation. And he did also mention Gloria Chu's paper on a GVHD patient as well who had developed a Desmetocele and was. So if you have these patients in your practice, I would really encourage, it's so nice to have these papers out there because they can help guide, of course, this isn't something we're seeing every day in most of our practices. So really important to see what worked and what didn't work. So a lot of good discussion about that in the session as well. So now, last but not least of this session was Tom Arnold, my neighbor here in Houston. He showed a really interesting case, and he had published with some of our colleagues in Australia about post-RK patients and had looked at some post-RK patients and compared the corneal edema. And so just quickly reviewing his results, he found that the RK corneas did swell a little bit more than the normal controls. And if you see here, really this bottom graph is interesting. And what this red line here that seems further away from the others, that's as you get further out into the periphery of the cornea. So ultimately what they found is that you do get more swelling in RK corneas, specifically in the location, and is also correlated to the depth of the incisions. So really, really interesting talk there. I'm going to skip that just to go here real quick. really interesting discussions in this second session as well. So a couple highlights talking about using K-pros and fitting corneal transplants. Remembering we had Jia Yin, who's the corneal specialist there, was really gave some good insights. Talked even about insurance coverage, spectacle blur after RK. So check out those recordings on our website if you haven't already, and they're not even really up yet. So I promise you they'll be up tomorrow. I know a couple people have emailed. Anyways, moving on. So Gloria Chu, one of my favorite speakers and presenters in general, and clinicians. She's just a really amazing. She's a lot of disease dyes and really smart, always reading and keeping up with everything that's going on. So Gloria talked a lot in the super session, or a bit about some of her really nice work done looking at microorganism contamination and growth in different saline solutions. And ultimately, she did find that bacteria can grow and persist in open bottles and saline vials. And you can see I've just got an example of all the solutions that we typically use for filling the scleral lens bowl. So it is important to educate. She did point out that contamination does not mean adverse event, and that's important for us to realize, right? And we've got all the bacteria and the microbiota on the ocular surface and lids already, so it's not necessarily indicative of an adverse event, but something certainly to be considered. Okay, and then as a reminder, and Gloria had reminded us in the lecture, that there's many preservative-free options that can be used to fill the chamber. As you saw in that other session, targeted therapeutics such as Avastin or antibiotics may be indicated. And we also have all these new preservative-free medications like anti-allergy, immunosuppressants, preservative-free tears, and all sorts of fun and exciting stuff. So hopefully, I've had a lot of fun, honestly, in the past couple of months, really pushing and integrating new types of therapeutics in scleral lenses for patients that need them. So, okay, and it's like the run through quick here. So session 3, one of the best sessions we had at the IFSLR. And they were all great, but this was an interesting one, and certainly had a lot of technology talked about in this session. So it started with Gunyang Yoon, who really nicely, I think, pointed out the main limitations. So he started talking about presbyopia optics in scleral lenses, and really outlined right, that the discrete foci, right? The fact that you can only get multifocal lens, you lose light and you lose focality in those. And then beyond just the general, having to focus at multiple distances at once, you also have the added issue of ocular aberrations, especially with our patients with irregular corneas. And then again, we see the decentration of optics kind of comes back and is something that we have to very seriously consider with these patients. So a super interesting design that I'll just focus on this left side. This is one of his slides as well. What you see here is basically a zero power, or effective zero power, in the center of the lens. And then those yellow to blue concentric circles is the power going up to 2.5 and then back down to 2 and then up to 2. So it's basically just these little inlets. And he talked a lot. Again, you're going to have to go listen to what he was talking about to really appreciate the optics. He had some really nice slides on looking at the different types of diffraction versus refraction based optics. But this is a new type, or this is a unique type of extended depth of focus. So this EDOF is the kind of term he was talking about and was encouraging us to use. And then, of course, he showed us some data from his own wavefront guided scleral lenses. And you can see when you have a conventional scleral lens, so still wearing a scleral lens, you can see these amounts, and the magnitude of direction is somewhat arbitrary, but the further away from the midline at 0, the lines extend, the worse it is. So you can see conventional, the blue lines, larger amounts of aberrations and then less with the wavefront guided. Okay, last video, and this is Gonzalo Caracedo. And actually, sorry guys, for the sake of time, because I sort of snuck this in because I thought I might be running low on time. So you'll have to listen to the recording to hear him talk. But I took screenshots of what he actually said. So he basically, again, stress the impact of not just of the centration of the lens, because sometimes you can't help that, as he was pointing out, but also the centration of the optics. So what he was showing and what you can see on this top image here is that a decentered lens, so this is the effect of lens decentration. You get these, which coma is your Z31s, right? So your higher third order Zernike aberrations, your coma is higher values. Then here, if you look at the bottom, when you center up the optical zone, and he really nicely points out that these can be decentered and that patients do much better when we decenter this optic in the scleral lenses to better align with their pupil. So really, really some interesting stuff. And then in terms of practical higher order aberration fitting, we also heard from Greg Gammules in that third session. And he shared his use of using the OCT and using the aberrometry. And you can see some of his lens designs on the bottom right-hand image here. And really, he's very specifically designing these lenses because, again, reminding us about centration and also rotational stability of the lens. But in doing this, he was able to reduce the higher order aberrations of his patients by 45%. So really quite impressive. And then lastly, just bringing it together again, and this is again back over to our super session with Jason Jedlicott, and he mentioned this a few times. And I added here Jason's tips for maximizing lens centration because I talked so much about it and it was talked about so much at GSLS. I thought I'd share his tips, and I think I do not need to introduce Jason. We all know who he is at Indiana. Lowest vault possible, and he also emphasized not to overvault the limbus. He's a big fan, and I agree with this, of checking that landing zone in primary gaze. So pushing the lens to the center and evaluating that. That's what we do with GP lenses. So I think it's more and more becoming what we do with the scleral lenses. So center the lens and then evaluate the landing area. And then also maximizing the lens to eye surface area. So not having any lens that's essentially aligning the lens as well as you can to the eye. So really advocating, especially for these advanced optical designs, really advocating for as customized a landing area as you can possibly get. And just as a final thought, decentered scleral lenses can affect optics comfort, landing zone, a lot of complications. This is a picture of one of my patients with a very decentered lens on OCT. So I think that was a nice theme of GSLS. And with that, I'm going to go ahead and pass it over to Dr. Dan, and he is going to bring us into the world of posters.
Okay, well, thank you very much, Maria. That was fabulous. And for those of you that hadn't had a chance to attend GSLS before, this is really like drinking from a fire hose the whole time you're there. There's so much information to get in such a short period of time. So it's really helpful to have somebody with Maria's background kind of digest it all and present it in a summary form. So I'm going to pick up with the posters, as we said. Let's see if I've got control back here. Okay. And so there were quite a few posters there, 184 as you can see there. And the bulk of those are case reports. They're very good about supporting our residents. This is my current resident here, Dr. Aspen Chung, and she's doing a fabulous job. Wants a job outside of Tennessee, so those of you that are interested, reach out to her or me. And you can see disproportionately case reports outnumbered the amount of research that's there. And it's a good place to kind of see little snippets of research as well as some industry presented research. And so I'm going to run through basically these four categories here and summarize them for you rather than sit here and give you 184 posters to go through. Okay, let's see, next slide. All right, thank you. All right, so this one is by Ellen Shorter, and what she was doing was something along the lines of what you saw Maria present with the scope group that's been going on now for at least 5 years, maybe longer at this point. And they're always producing some really interesting insights by surveying practitioners to find out what's actually happening out in the field so that ivory tower types like ourselves don't get too disconnected from what's being done in the field. So she surveyed, or they surveyed as a group, the 2020 attendees that had fit at least 5 scleral lenses. And so there were about 781 respondents. And what they found was there was no consensus on the best practices and standards of care for what you do when they come back for evaluation of their lens fits, either periodically or in progress after the initial fitting. And what you see in the graph here, I know some of these graphs are going to be a little bit difficult to see, but things like IOP, cover test, corneal staining, conjunctival staining, everting the lids, dry eye questionnaires, and quality of life questionnaires. So some of those probably seem pretty reasonable to you, that unless you're fitting ocular surface disease patients, you probably are going to be a little bit unlikely to do any kind of questionnaire with the patient. Doing other things like IOP, which Maria alluded to as a controversy about whether it does or doesn't increase the eye pressure, and whether it does or doesn't to a clinically significant amount is an area of interest and investigation for the researchers. But things like cover test and basic primary care skills are not being done consistently across the board by the practitioners that were surveyed in this cohort. And it's kind of interesting. So, you know, I think a couple takeaways that I would give you from this poster is that don't forget that you are their primary care practitioner in most cases. You're seldom just doing scleral lenses alone. And we manage a large number of patients with ophthalmology groups and corneal specialists. And it's very easy in those handoffs, if you're not communicating well, to forget doing things like IOPs and looking in the back of the eye and dilating regularly. So good to remember that you're a primary care practitioner first, and that you should be looking at those things as they come in at least once a year, other things more often depending on what their underlying problems are. Okay, so let me see if we go to the next slide. Thank you. And another one that was a survey that was done was by Randy Kojima and his group at Pacific. And what they did was they looked at a single lab. It was, in this case, it happened to be Optical. And you'll see that there's a little bit of hidden data in terms of how many respondents and practices were looked at and what the total responses were overall, because that was proprietary information that ART reasonably wanted to protect. But what they found was that, at least in this one setting here, that the parameters that are being fit are typically fit within a 400 micron sag range, and at least 72% of the time. And it's kind of interesting, if you look at your trial sets and you look at a number of trial sets as we do, typically on the shallow side, they're going to be around 3,800 for maybe normal corneas. And they may go to an extreme range of somewhere 5,500, 5,800 even. So you're going to see that range, and they'll be broken up in maybe 200-300 micron steps, depending on how many lenses they put in the trial set for you. So this is kind of giving insights into how they might want to develop their trial sets. More than 88% of them were fit within a fairly narrow range of about 800 microns, and that obviously I think reflects the range of probably keratoconic patients more so than it does any kind of post-surgical eyes or ocular surface disease patients. And almost 80% again were greater than 16 millimeters in diameter. That information is pretty consistent with other work from the SCOPE study that looked at similar sorts of things and found that most practitioners were fitting between maybe the 15.5 and 16.5 range. As you go to ocular surface disease patients, you may typically find that that diameter is a little bit larger. The most common modifications, no surprise here to those of us that fit a lot of these lenses, are going to be in that transition zone, and to a lesser extent, maybe in the toricity of the landing zone. And you can see there that the typical amount of toricity in this line of products for this company was between 100 and 200 microns in toricity between the major and the minor axes for the curvatures in that landing zone. And only about 13% of the lenses that they looked at were done with anterior toricity to correct for residual astigmatism. So I thought that this was rather interesting, and it does seem to track fairly closely with my own clinical experience, and we certainly fit a large number of lenses at Southern College, more so than most private practitioners would or would even care to, in terms of the diversity of sets. But I think it is somewhat instructive in terms of thinking about your approach to which lenses you pick and which designs you want to work with. Next slide, please. This is another solution slide here. Sadly, this study had a relatively low number of enrollees in it. This was done during the onset of the COVID period. So full disclosure, they indicated that certainly disrupted their ability to bring subjects in and evaluate things in person because of the social distancing requirements and so on. Those of us that do clinical studies have had to incorporate some statement about COVIDs into our IRB protocols when we submit them as well. So it can certainly throw a monkey wrench into study enrollment. But nonetheless, I thought it was rather interesting to look at. What they did here is they compared two particular FDA-approved filling solutions that are buffered and tried to see if there was any kind of difference between those, and basically in terms of the OSDI scores and the duration of their wearing times. And they didn't find any clinically or statistically significant differences between the two. It's worth noting that the FDA-approved solutions that are out there now are all buffered, if I'm not mistaken. And you know, quite honestly, I get asked that question a lot about what solutions we use. Do we use the ADDI-PAC solutions? I would tell you no, there's really not much point in using those anymore these days unless you're finding it difficult to source the other ones, because the other solutions are FDA approved. And there is some differences between them in terms of things like neutrophil having different electrolytes and things in the solution as well. So at least in this very, very, very small study, more of a case series, they didn't find a difference. But these are oftentimes interesting posters that give you pause for thought and serve as a jumping off point to maybe do a larger study. Next slide, please. So this is an interesting presentation by Doug Benoit, and it was done looking at the natural view lens from Vision Nearing Technologies that is also an extended depth of focus lens. It's not FDA approved for the indication of myopia control, but there are certainly people out there using it for that purpose. And so they did a little bit of an experiment here to see with 196 subjects what kind of differences they were finding, if any, in the rate of progression and changes from baseline over time. This study was done in multiple sites. It was done retrospectively, so it does have some limitations because of it. They did have controls there that were age and race matched, which is very helpful. Obviously, we know folks of Asian ancestry are going to have higher propensity for progression than, say, Caucasians are. They looked at the spherical equivalent refraction, and they looked at the axial length values and didn't find any difference between the control groups and the study groups. And as they went through, you can see the age and years were in that 12.3 to 2.8 range. It's kind of at the high end of the sweet spot for where we like to catch patients between the 8 and the 12-year-old range earlier if we can. But we know that there is a trend towards deceleration as they age. And what they found was basically there was an 85% decrease in the rate of change compared to baseline in terms of the progression of myopia and diopters, and that there was a 95% decrease for the subjects as well in terms of the rate of progression. And 78% of the subjects, or excuse me, 95% of the subjects experienced a decrease in rate, with about 78% of the group experiencing more than a 70% reduction in the rate of progression. So that's a lot of statistics throwing around there, but it's basically telling you that it has a pretty large impact on the rate of progression overall, and that 67% showed no increase in progression over a 72-month period. So it's a relatively long look back in the retrospective study, and telling you a little bit something about how efficacious it may be over time. And the axial length was looked at as well as the dioptric progression, and they found that it really was no different than the emmetropes were. So further indication that you're kind of holding things the same in terms of the growth of the eye while controlling the rates of progression over time. And as we said, it's a rather long look back and study. So we can jump to the next slide. Thank you. And looking at other effects in the myopic progression and myopic control world, there's been this discussion in Ortho K lenses for some time about the differences in treatment zone size as to whether or not that has a greater or lesser effect on the progression of myopia over time. So Randy Kajima and his group again did a really nice study here, and they included both adults and kids, so that can influence the outcomes, of course, because adults are more or less stable where children are not, or pediatrics are not. It's also a retrospective study, which gives it some limitations as well. They used the med mount, and they were looking at what they called the myopia defocus dosage and the amount of anterior spherical aberration that's present in the treatment zones. And so they looked at basically two different zones, a 6 millimeter zone and a 5.5 millimeter zone. If you look at the distribution of the subjects, they're not exactly randomly distributed, so you've got kind of an overweighted group in the 6.0 zone and an underweight in the 5.5 millimeter zone. But interestingly, it did show that the or tend to trend towards where the smaller optic zones may produce a stronger myopia defocus dosage or control signal over time as well. And you can see that they also were able to measure the spherical aberrations and found that those were also greater in that smaller zone as well. So let's see here. I want to check my messages as they come in. All right, so let's go to the next slide then. All right, and kind of keeping with that same theme, they were looking at spherical aberrations that were varying again with the optic zone size. So picking up after that last slide, this is also from the same group, different first author, and they randomized eyes to the Moon lens, and the Moon lens is an art optical product. It's an Ortho K lens, overnight Ortho K, and they looked at what the response was for the subjects at both 1 night and at 7 nights, or a week later. They again used the med mount to look at the curvature data, and they used the NIDEC to look at the spherical aberration data. If you haven't used the NIDEC OPD device, Marco distributes it, and it's very useful, I think, to measure a variety of different things, including pupil sizes, mesopic and photopic pupil size, looking at wavefront refractions as well as standard auto refractions and Ks, and it does a nice corneal topography as well. It's got a Placido's disc topographer on it. It also gives you a retroillumination of the lens that is very useful when you're trying to find out whether somebody has reduction in vision that's due to a cataract, for example, before you take them back into the exam room. It's also a nice device to look at. As Maria was talking about, a number of studies we're very interested in the lens centration. You can do the corneal topography over the contact lenses that they're wearing and look at the relationship of that centration to the underlying pupil outline. And so it's very useful for kind of troubleshooting scleral lenses and multifocal lenses and all kinds of lenses where the patient may be experiencing decrease in vision that's not correctable by, say, an over-refraction. So what they found here was, again, that decreasing the optic zone size increased the amount of spherical aberration, just as we saw on the last slide. We can go to the next slide. Okay, and one more for Ortho K, and I think it's worth throwing these in because there's obviously a lot of interest in myopia control. It's not all about soft lenses, but Ortho K has been out there for a lot longer, and so we don't want to forget that in our toolbox, as Maria was saying, where we can have a lot of different options out there for patients of different ages, difference between myopia control and myopia progression. So we're concerned about progression in the pediatric population, but we can control these things for adults as well. Again, looking at differences in treatment zone size between the 5mm and the 6mm zone. This time they used the CRT lens from Paragon. You may know that Paragon was acquired by CooperVision Specialty Lenses, and that's where you'll find most of the information coming from nowadays as well. It's a prospective randomized study, so this one's prospective where the others were retrospective. They used a contralateral eye as a control, so they put a 5mm lens in one eye and a 6mm lens in the other eye. They did that for a month, and then they crossed over and switched which eye had which lens at that 1 month point with a 1 to 2 week washout in between. They had 18 subjects in the study, so it's a relatively small study. And you can look at the baseline information there where they're about a -3 with basically less than a diopter of cylinder. And the test lens showed, or the 5mm lens showed a more rapid onset of the effect of the Ortho K. But by the time they got to that 1 month crossover, there was no difference between the 5mm and the 6mm in terms of where they were at in terms of the effectiveness of the treatment. So what it says is that the smaller optic zone can safely and effectively correct myopia over time, and it may have that added advantage based on what we saw in the other studies of perhaps giving a little bit more spherical aberration that can help with myopia control over time. And I think we can go to the next slide then. Okay, so now from the realms of ocular biometry and devices, Dr. Randy Kojima again looked at peripheral corneal shape, and I think by now we've all heard the results of the Scleral Lens study, Scleral Lens shape study group with Greg Denaire and many others that have enlightened us to the fact that the scleral profile is not rotationally symmetric, that about 62% of the time it's going to be something other than rotationally symmetric in varying degrees, and only about 5.7% of the time is it going to be rotationally symmetric. So what he did in his group, they looked at the scleral shape and they said, well, how does that shape vary as you move out in different chord lengths from the center of the cornea, and does that have any implications for how we should be designing Ortho K lenses? And what they found when they looked at 8, 9, 10, and 11mm chords in all the major meridians, and what they did is they used fitting modules for 3 globally available lens designs, and then they compared the results to see if it would have resulted in a change in how those modules would have been fit over time, if that's not too confusing for you. And it's a little bit more robust study. They looked at 164 eyes, and what they found was the rate of flattening increased as the chord length increased on the cornea. So not too surprising because we know the eye has a prolate shape, right? So it's steeper in the center and flatter as we get to the edge. And what they found was there was a clinically significant difference when you went from 2mm increments between chords, but not so much when you went less than 2mm between chords. So if you change from 8 to 9mm, it's not as big a difference as it is going from 8 to 10mm or 9 to 11 in terms of the chord length. So there is some threshold is what that's suggesting in chord length changes that induce a clinically significant change in the fit of the Ortho K lenses using these standard modules that are out there. And what they're suggesting for their takeaway from the study is that perhaps we ought to be thinking about this as we go into fitting these lenses going forward in the future. We can go to the next slide here. And Roxana, feel free to jump in anytime you want to cut me off, and we can go to some questions. They looked at, this was an important study from Jason Marsack, colleague of Maria's down there at Houston, and one of the foremost thinkers in the area of wavefront guided correction of lenses, known very well for what they've tried to do with scleral lenses. But here's an example of where they tried to apply the same technology to soft lenses. In fact, this was one of the award-winning posters presented at the meeting, and very fascinating results. And they looked at the natural soft lens, which is a product from AVT, Keith Parker and Janine Bonanno out in Colorado. And they used the next wave aberrometer to look at the Zernike sums. And what they found is, as Maria was saying in her presentation, that centration matters a lot. And things, of course, like pupil size and the amount of drape of the lens, accommodation, tear film stability, all these things matter when you start talking about higher order aberrations. But what they tried to do was make these lathe cut soft lenses and incorporate the waveguide correcting, aberration correcting lenses in there, and wanted to see if that could be done faithfully and transferred to a soft lens first, without too much in the way of overshoots or undershoots, and then trying to get the lenses centered. And so here you can see basically the graph, the blue and the orange dots, basically showing you that they're fairly close together, and basically an indication that they're able to faithfully transfer from a technical standpoint the aberration correction to the soft lens. And so the next challenge and the real challenge is, can you get that centered over the pupil or over the visual axis? Since we know the pupil is not dead center under the lens, we know it's decentered typically nasal about 1 millimeter, maybe up a half millimeter or so, looking at the angle alpha and angle kappas out there. So having the ability to decenter those optics in a soft lens is certainly a technology that exists out there already. And so here we're ready to kind of layer one technology on another. And so very exciting work for our ability to improve patient visibility here. When we talk about wave correcting lenses in general, particularly on the scleral side, there's not a lot of data on how much improvement you get, but there are at least, I can think of about 2 publications out there that suggest that you gain about 1.5 to maybe 2 lines of vision improvement. So that is significant clinically as well as statistically. And I think if we're able to do the same thing for our soft lens patients, that may be a good thing, especially in the multifocal realm. But we all have these soft lens patients that come in that say, yeah, I know what you're saying, doc. You're saying I see 20/15, but I'm telling you I can't see. So for those patients, these types of corrections may be very helpful. We can go to the next slide. Here's another application in a case report, kind of showing the same sort of thing. This one they did in a post-LASIK ectasia, and this is actually a rigid lens. And what they found was about I want to say, let's see, 65% improvement or so, I think is what the poster had said. But basically, it eliminated the ghosting and the glare complaints, and you can look at the point spread functions, those little black charts off to the side here in that middle column that kind of show you how a point of light is smeared out in response to exposure to these higher order aberrations, that you can still have patients that are corrected optically fairly decently, but then still complain about things that are caused by the higher order aberrations, such as ghosting and glare and halos and those kind of things. And we have learned from these studies that are out there that the differences in contrast are at least as important, perhaps, as some of the higher order aberrations that we're correcting and trying to get the patients to see subjectively as well as they can. We can go to the next slide. rounding the clubhouse turn here. This was kind of a very sciencey one from our friends at Alcon, basically looking at the dailies total 30 lens, or the monthly total 30s lens, I should say. And they looked at two basic characteristics: the softness of the lens surface and also the lubricity of the surface. We know that lubricity does matter. Softness, that's a little bit harder to appreciate, but they did it with an environmental scanning electron microscope and an atomic force microscope to look at the surface properties for softness. And they looked at tribometry, which is the measure of how things slide across a surface, basically, against the fluid frictions. And they found that with this product, compared to at least the 3 comparator lenses there, that there was a very significant difference between the lenses. So if you if you haven't worked with these polymers that are out there now, we're kind of in the 4th or 5th generation of Sci-Hi polymers now that have a lot of bulk and surface property differences from what the 1st and the 2nd gen polymers have. So it's probably a good time to try and experiment with those and spend some time using them. Let's try the next slide. And I think this is our last one. This one's another fairly sciencey slide, and what they did was looking at the UV transmissibility characteristics of a number of commonly available soft lenses that are out there, dailies as well as monthly lenses. Some that make the manufacturers claim that they block UV light, others that don't promote that they block it, but they use those as comparisons. And what you can see is that overall, they averaged a decrease of about 43% blocking of the UVA, and about 90% of them blocked some amount, or excuse me, about 10 of the lenses blocked 90%, 9 of them blocked 60 to 70%, 3 of them blocked 100, I think that's probably supposed to be 10.5 to 30%, and 15 blocked less than 5%. So even lenses that don't promote it have some capacity to block UV light. Question is, what's significant in terms of blocking UVA and UVB? This only looked at UVA, and so it does say that there are higher capabilities in those that are promoting UV blocking effects. So they're conservative in promoting that to you. They're not overselling it for the UV blocking ability. It actually can do the job better than what they're promoting it to do. So with that, I think we're done with the main presentation. I do want to put a plug in for the Scleral Lens Education Society, since that is our host tonight, and I am the president. So if you haven't been to sclerallens.org, please check in on the site there. We will have these webinars archived for you there. You can be a member just for signing up. We'd love to have more fellows, and I think I can speak for all of us in the society that we all are interested in having new additions to our committees, and folks that are interested in rotating through the chairs of leadership as time goes on. We are a volunteer organization, and many hands makes light work. So if we could get more volunteers, we'd love to have you. And going through the fellowship process is not impossible. And so we encourage you to do that. So with that, I'll turn it back over to Roxana to talk about upcoming shows.
That was a great plug. I agree. We would always love to have people to help. And thank you to Maria and Dan for this awesome lecture. I wasn't able to attend GSLS, so this was a great lecture for me to kind of feel like I was there and get that full update. We do have a couple quick questions. One was if these papers or the videos that you guys had are available on the GSLS website, or where people can get access to those.
So so the handouts from tonight, I actually just sent Ursula. So I think somebody emailed her asking them, so she'll send them. If you do want them, you can let us know. But those are just the handouts from here. I will tell you, because I went on and looked, if you go on the GSLS website, you can see most of the posters. There's PDFs up there. As for the IFSLR talks, those will be up honestly, probably tomorrow. They'll be up at least on our YouTube channel tomorrow, maybe tonight if I don't go right to bed after this.
And I would echo that. I picked specifically posters that were presented on Penavision's site for GSLS 2022 in their archives, and there's a lot more information there, and they go through disclosing what their limitations were and proposing future directions for study. So I would direct you there as being probably the best source for a comprehensive look at the posters.
Okay, awesome.
Yeah.
Thank
Roxy, you probably said this, but this actual webinar is also, of course, uploaded to our website. So.
Yes, no, I hadn't said it yet, so I'm glad you said it. Yes, all of the webinars for the Scleral Lens Society, including tonight's, will be available on the website, usually within the next week or sometimes within 24 hours. So definitely keep an eye out for that. If you missed something, you want to rewatch it, we'll have that info there. And then there was a question about fitting scleral lenses with or without OCTs. If anyone fits scleral lenses without having an OCT, or if you need an OCT to fit a scleral lens.
It's not an essential thing to have, but it can sure solve a lot of problems and be helpful. Certainly looking at the amount of clearances using fluorescein in the reservoir when you're doing the initial fit, or using optic sections in white light when they return can be helpful. I think it's where you get into issues where it can be helpful is when you're wondering whether an edge is digging in or burying too much. For that, you can look at whether there's an indentation ring or rebound hyperemia when you remove the lens. If you're concerned about touch, you can certainly look at the limbal areas and look for microcystic edema. You can look for corneal staining and indicators that you've got some mechanical touch in there agitating the surfaces. If you're standing off too much, that gets a little bit harder, but you can still look for microcystic changes due to hypoxia and that sort of thing. And it takes practice to get good about judging the clearances. The Michigan College of Optometry template has photographic images that you can compare against. We use those all the time when we're teaching this in the society, and using basically the thickness of the known thickness of the trial lens that you're using as a comparator against the fluid reservoir thickness is a reliable way to judge, but it takes a little bit of practice getting there.
Awesome.
Yeah, I'd agree with Dan. I would also just comment, I know on one of my slides with Greg Gemuels, he uses the OCT to design his lenses. But again, it's not necessary. And so if somebody was referring to like the custom wavefront or anything, not necessary. You just need to be able to somehow get a stable lens. And the OCT, I agree with Dan. It can be helpful, but the least on your list of things to get.
I think we could talk about scleral lenses all night, and Maria has just triggered another idea. So I'll give a little inside baseball to Dr. Hamadi. A great topic for future lectures might be looking at custom designing lenses, including things like the Wave software and iSpace and others, since I think our audience can tell from tonight that the trend is absolutely towards more and more customized designs.
That's a great idea for sure. No, I appreciate that. Well, thank you again, Maria and Dan, for this awesome summary of GSLS this year. Hopefully we'll all be together next year. And then our next webinar is going to be on March 16th. It's going to be by Dr. Caitlin Morrison and Dr. Elise Kramer, and it is going to be on organizing your scleral lens practice. So we hope you can join us for that next webinar on March 16th.
Thank you.
Thanks, everybody.